From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson.
Today is Wednesday, the 25th of June, 2025. Today's LabMind topic is clinical guidelines, something that is extremely important in our world of clinical medicine, something that I feel like we take for granted much of the time. And I've never been quite certain if we fully appreciate the amount of work that goes into them, some of the subtleties, how we should read them critically. And our guest today, Dr. Ryan Metcalf, will be helping us understand these issues. He just published a major guideline on platelet transfusion that we will be discussing. Dr. Metcalf is Section Chief of Transfusion Medicine at University of Utah Health and ARUP Laboratories. He completed Pathology residency and a Transfusion Medicine fellowship at Stanford University. He's currently Associate Professor of Pathology at the University of Utah and is also a 3-time prior guest on this podcast. So if you like our discussion, please go back and listen to our others. One last note, Dr. Metcalf recently recorded a half-hour presentation describing the platelet transfusion guideline that we'll be discussing today. So if you'd like a more comprehensive, but I promise it's pretty concise, description of what's in the guideline, go to ARUP's education website where you can find the recorded video. And we will provide a link to it in our show notes. Ryan Metcalf, welcome again to LabMind.
Thanks so much for having me, Brian. It's great to be back.
So first of all, a huge congratulations. A first author paper in JAMA is something that all of us fantasize of. I have not yet come close to this in my life. So well done.
There were 42 authors on the paper, so it was a lot of work by a lot of people, especially on the steering committee. So yeah, appreciate that.
Also note that you were recently interviewed by the JAMA editor for the JAMA Clinical Reviews podcast. So we'll put a link to that as well on the site. So what was this guideline all about?
So the focus of the guideline was we have major blood components that we use for transfusion: red blood cells, platelets, plasma, cryoprecipitate, also whole blood now. And platelets are one of those major components. We do about 2.2 million platelet transfusions per year in the United States. And the decision clinicians make about when to give a platelet transfusion should be ideally evidence-based as much as possible, balancing risks and benefits. And so really the focus of this guideline was to evaluate the evidence and make recommendations to help clinicians make optimal decisions as to when to give a platelet transfusion or to not give perhaps a platelet transfusion to an individual patient.
So this was under the auspices of AABB, and what's the international?
The ICTMG is the International Collaboration for Transfusion Medicine Guidelines.
I believe there have been existing platelet transfusion guidance out there. Is this a significant update?
It is. So about 10 years ago, both organizations, the AABB and the ICTMG, published platelet transfusion guidelines. And there have been studies published since, trials published since, so it made sense to think about updating the guidelines to make sure that we're up to date in terms of evidence-based recommendations. And we thought for this particular effort, it might make sense to join forces and get together and do a collaboration for hopefully a somewhat go-to resource for people wondering about how they should transfuse platelets. So that was sort of the genesis. And then for this guideline, we made 11 recommendations, and several of them are either new or do represent significant practice changes. So of the 11, 3 are fairly similar, and the rest are essentially new or updates.
And you were able to get the Americans and the Europeans to all agree on the outcome, right?
Yeah, we had people from other continents. We had a large panel and got together and discussed the evidence and formulated recommendations together. So it was, I think, had some spirited debate, but largely we were able to achieve consensus, which was great.
So when most of us who are not blood bankers think about platelet transfusion, we probably have a pretty simplified sense of the decision-making that goes into it. But I believe there are actually a lot of different decisions involved.
There's a common rationale in different clinical settings for why you might consider a platelet transfusion. So in patients with thrombocytopenia, so a low platelet count, or with platelet dysfunction, the idea of if you were to give a platelet transfusion would be to transfuse the patient to increase the platelet count and hope that that either prevents important bleeding or treats already existing bleeding. So that's sort of the rationale and the intent of administering a platelet transfusion. And then On the flip side of that, you have to think of potential downsides, harms, for example. And platelets do come with the highest risk of adverse events compared to the other blood components. So most patients do not experience an obvious adverse event from a platelet transfusion, but there still is risk, and that's important. And we do these guidelines thinking about the individual patient perspective, potential benefits, risks, and then we also have values and preferences to think about. So another thing that we thought about was quality of life, for example. So comparing different transfusion strategies, a patient may want to not have to come into clinic for a platelet transfusion if it's unnecessary and unlikely to provide them benefit. So that's an important sort of quality of life consideration. And when we think about outcomes that are important, we voted essentially. And so things like mortality or bleeding were the most important outcomes that we voted on. And that's really what we focused on when we evaluated the evidence. And in the absence of a difference, comparing different transfusion strategies for those most important outcomes, then we start to think about other outcomes that are still important. And this is going back to the overarching analytical framework that we use. So our analytical framework was essentially comparing what we called restrictive platelet transfusion strategies to liberal platelet transfusion strategies. And this is similar to trials, if listeners may be familiar, for red blood cell transfusion. There are many trials comparing restrictive and liberal red blood cell transfusion strategies looking at hemoglobin thresholds. So a lower hemoglobin threshold, say of less than 7 grams per deciliter, would be restrictive, and higher, 9 or 10 grams per deciliter, as your threshold, being liberal. So you can apply that same paradigm to platelet transfusion, actually, where the restrictive strategies would be sort of less aggressive or transfusing fewer amounts of platelets, whereas liberal would be the opposite of that, or a more intensive approach to platelet transfusion.
So, on the red cell transfusion analogy here, one of the things that caught my eye in your paper was that you said that red cell transfusions have decreased over the years. And I'm assuming they've decreased due to maybe greater appreciation and a strong scientific basis for understanding that less is more for a lot of these patients. But you said that platelet transfusions have not decreased. Do you have a theory as to what's going on here?
In the United States and certain other countries like the UK and Canada, red blood cells have decreased in recent years. We had a peak in the United States around 2008, and then we've seen a reduction of 20 to 30%, actually in all three of those countries for red blood cell transfusion.
That's a lot.
It's a lot. And, one could think, we've got more randomized trials that have accumulated over time. And the general effect was no difference between restrictive and liberal for the most important outcome evaluated, which was 30-day mortality. So in the absence of a difference between restrictive and liberal, we would recommend restrictive strategies, which we know for sure reduce the number of transfusions performed. So that's the evidence and the guidelines. And if you implement the guidelines, then you would expect to see a reduction in transfusions. So that's probably what happened for red blood cells. And for platelet transfusion, as you mentioned, it's been quite stable, or if anything, slightly increased over time in the United States and UK and Canada. We've accumulated more evidence over time. So more of the recent evidence showed even some paradoxical results, some evidence of harm from randomized trials. And so these guidelines are new, and our overarching recommendation was for restrictive platelet transfusion strategies, which is new. And so with the implementation of guidelines like these in a country like the United States, we would expect, if we can effectively implement, potentially a substantial reduction in the number of platelet transfusions. And interestingly, there's probably country to country variation as well. So when you look at a country like the United States, even adjusted for per 1,000 persons in the population, we do about 1.5 times the number of platelet transfusions in the US compared to Canada and the UK.
Interesting. Have people tried to measure outcome differences across those countries?
I think it raises a lot of different questions. I would say the short answer is we probably don't have a direct comparison related to how that could impact patient outcomes. You'd have to think about confounding variables to differences in baseline risk of the population and so forth. But at that large scale, I'm not sure we have the analysis at this time.
One obvious difference between the US and the other two countries you mentioned is that the US is very litigious. We have a lot of malpractice lawsuits. Do you think that's likely to be a factor here?
This was brought up, and we did add a couple of sentences mentioning concerns about litigation because when we looked at the evidence comparing restrictive and liberal, in some populations, the risk of bleeding still remained. It wasn't importantly changed whether you used a restrictive strategy or a liberal strategy, but the patient may still have an important risk of bleeding. It's just that platelets didn't really modify that risk. And so you can understand at least the psychology that the clinicians going through thinking about this. The patient has a low platelet count. They have this risk of bleeding, let's say, and I might be interested in administering platelets. But we did, for that reason, mention in part of our good practice statement that essentially this is a guideline for patient care. It's not meant for legal proceedings, but hopefully this can help guide people, mentioning that this baseline risk still remains, but hopefully help clinicians avoid administering some unnecessary platelet transfusions due to concerns about litigation, but really, again, focusing on the individual patient and the risk and benefit and acknowledging there are unequivocal risks to administering unnecessary platelet transfusions.
So maybe we should lay out these risks just to be really explicit here. You mentioned that the most important outcomes were serious bleeding and death.
Yes.
Those are sort of the most visible, short-term, obvious outcomes. So that makes sense. What are the other harms, either over or under transfusing?
Right. And to be clear, so if we saw clear evidence that liberal strategies reduced death or reduced important bleeding, then we would have stopped and made recommendations in favor of liberal. But in the absence of a clear difference, that's when we turn our attention to these other less important but still important outcomes like adverse events. So you could think about transfusion reactions. And so the rates of transfusion reactions, that's something that I'm interested in, the epidemiology of the rates of transfusion reactions. One of the challenges of studying them is that we rely on passive surveillance. So we rely on clinicians or clinical teams to report suspected adverse events to the transfusion service. And these are known to be underreporting if you use passive surveillance, which the vast majority of hospitals do. But in the active surveillance studies that we've done and some other groups have done, you could start to think about what are the types of reactions and what's the numerical risks associated with these reactions. So the overall risk of tangible adverse event due to a platelet transfusion that we're aware of is probably somewhere on the order of 2 to 5%, I would say. We've done studies looking at particular adverse events, synthesizing the evidence. So for example, transfusion-associated circulatory overload, volume overload, that's the number one cause of death due to blood transfusion. On a per patient basis, the risk is about 22 in 1,000 that we estimated from our studies. And again, the risks with platelets tend to be a little bit higher. We have risks of bacterial contamination. If bacteria proliferate in the platelet bag, it can cause a septic transfusion reaction due to a platelet transfusion. And platelets are stored at room temperature, so they're more amenable to bacterial proliferation. Now, hospitals use risk mitigation strategies, so the risk of that has reduced over time, but it's still a non-zero risk. We have allergic reaction.
And it's essentially impossible to get to zero with current technology, right?
Right. It's essentially impossible. Now risks of things like HIV or hepatitis C transmission have gotten much, much, much lower. So now the principal risks are these other acute adverse events that I was mentioning.
Yeah. So when you talk about transfusion reactions, are you including immunization, which makes the patient refractory to future transfusions?
Yeah, that's a great question. So we did think about this as a different type of adverse event. We have a table in the paper showing, estimated risks and number needed to harm. So number of patients you would transfuse before you would get a harm event. And we thought about including the risk of making antibodies to class 1 HLA antigens, but we ended up not including that in the paper. However, I think you could potentially consider it as an adverse event. One reason would be if somebody does have HLA alloantibodies, they can be refractory to platelet transfusions, meaning if you transfuse a platelet that has class 1 HLA antigens on it that are recognized by the recipient's antibodies, the platelet count won't increase in a way after transfusion that you might expect it when somebody is not refractory to platelet transfusion. So I think that is something that we probably should consider a form of an adverse event.
Now, it's not that rare, is it?
No, it is fairly common. We have several patients on our service right now for whom we're providing HLA selected platelets. So it's something that we try to support as much as possible, but limiting the risk of HLA alloimmunization is definitely one potential benefit of avoiding an unnecessary transfusion.
So another thing that struck me about the guideline and the way it was worded was that you included this thing that you called a clinical practice statement. Could you explain a little bit about what the thinking was behind that, what you were looking to accomplish?
Yeah, so it's the good practice statement. And one way to think of it is a look at the patient sort of statement. So, we have recommendations in specific patient populations. Many of them will include a recommendation either for no platelet transfusion or maybe a platelet count threshold at which you would consider transfusing. But sometimes there can be other things that you might want to think about that might modify your decision a little bit. So if your patient has a history of significant bleeding, if they're on anticoagulants currently, you might modify some of the decisions that you make based on potential increased risk. And maybe there's a higher likelihood of benefit for a particular patient population. Or if the randomized trials didn't study patients that are similar or ideally similar to your current patient, those could be reasons to consider sort of varying your approach a little bit, or conditional recommendations. So there are sort of two categories of strength of a recommendation that you make. A strong recommendation, which is where 90% or more of patients would want it, and you often sort of just do it, assuming the patient is consented to receive transfusion. And 50 to 90% of patients would want conditional recommendation. And that's often where you have less certainty of evidence. And especially for that latter category where you've made a recommendation that's conditional, ideally, one should have a discussion with the individual patient about their values and preferences, go over the risks and benefits, and then you can arrive at a decision that's best for that individual patient.
So, to your knowledge, are these good practice statements common in guidelines these days?
I think they can be fairly common. We certainly had a good practice statement for the red blood cell transfusion guidelines that we published in the same journal in 2023. Again, just recognizing that, that sometimes we may want to deviate from the guideline, but the guidelines in many ways should sort of be the default approach to practice.
So, where I'm going with this is that there's a tension between standardizing medical practice and personalizing medical practice. And I think that a big challenge with personalizing to the patient, which we talk a lot about, right? We talk about precision medicine, we talk about personalized medicine. That sounds very appealing. But the more we get into that, it can create tensions with this issue about, are you really standardizing based on the patient? Or are you standardized basing on the provider's preferences? And that's always been the challenge, but also the motivation for producing guidelines is to take the provider preferences either out of the picture or make them less prominent. So how do you think about the tension between personalized medicine and standardized guideline-driven medicine?
Yeah, that's a great question. When we think about randomized controlled trials that it's kind of the gold standard for generating evidence. If you have 1,000 patients in one study arm and 1,000 patients in another study arm, and you find a benefit to an intervention, does it mean that every single one of those 1,000 patients in the arm that benefited would actually tangibly benefit for whatever outcome you were looking at? May not be the case, and you could have some within study arm heterogeneity, which I think is partly what you might be getting at is ideally, how could we provide the best personalized strategies? And we actually put in the discussion of our paper the need for more research on more personalized approaches to transfusion. But the nice thing is that when we look at risks and the effects of interventions and so forth, one thing that's common in evidence-based medicine is that the relative impact of a clinical intervention, so let's say a liberal versus a restrictive platelet transfusion strategy, whatever that impact is to modify some important risks, say bleeding or mortality, it tends to be constant across different patient populations. So I think there may be a tendency to think about different patient populations as entirely different, but overwhelmingly in evidence-based medicine, about almost 9 times out of 10 from all the evidence that I've seen from multiple studies, relative impact of clinical interventions tends to be constant across different patient populations. And we actually considered this concept for our guidelines as well. We evaluated different populations together in one overarching analysis to see, did these appear to be constant? Was there any effect? Because we made 11 different recommendations, depending on how restrictive and liberal were implemented in different patient populations, we did evaluate the evidence in specific populations separately as well, because we weren't 100% sure that these relative effects would be constant across populations. But I think the overall impact of taking this approach, using grade methodology to put together the evidence and then transform the evidence into recommendations, is that the hope would be the vast majority of the time we're supporting the best decision based on the available evidence for the patient. But we do acknowledge that there's uncertainty. And this is part of the grade method too. So we may make a recommendation, a strong recommendation or a conditional recommendation, but we also do that based on a level of certainty of the evidence, which could be high, moderate, low, or very low. But one of the really nice things about grade methodology is that you express that uncertainty. So we may think, based on the available evidence, the best thing to do is A, but there's still some degree of uncertainty surrounding that. So one thing I like about it is sort of the transparency surrounding that method.
I think it would be fair to argue that the guideline that you published explicitly does a fair amount of personalization in the sense that it doesn't recommend one transfusion threshold for everyone. How many different thresholds showed up in the paper?
So we made 11 recommendations. Some of them were for no platelet transfusion in a particular clinical scenario. But, you're right. We first evaluated the evidence across all settings together and didn't find a clear evidence of benefit with liberal strategies. But we couldn't take that at that point and transform it into one single recommendation that says, let's transfuse restrictively. We thought clinicians would want more guidance because we have a figure in the paper. It's called a dumbbell chart where we show how they defined what restrictive was for a given population versus liberal. And it varied depending on the population. So in some, like hematology oncology patients, there's different trials that looked at very low platelet count thresholds, less than 10,000 platelet count, or even some had no platelet transfusion in the restrictive arm. So no platelets were given at all for prophylaxis.
No matter how low the patient gets, as long as they're not bleeding.
Bleeding, right, exactly. You can administer platelets in those trials. And sort of a different example on the other end of the spectrum would be patients with spontaneous intracranial hemorrhage, where primary evidence was generated from a trial of patients where the platelet count was above 100,000 already in terms of the inclusion criteria, at least for the trial. And so those are very different liberal definitions. If you look just at the liberal arms of those strategies, one would be a platelet count threshold of less than 10,000, and the other, you're considering giving platelets if the count is above 100,000 even. But interestingly, in both of those examples too, the restrictive arm is actually no platelet transfusion.
So it does matter where you're bleeding and the underlying disease process going on. I wonder if there are other factors that can, say, make a count of 10,000 in one person mean something different than a platelet count in someone else. Do most people have platelets that function approximately equally, as far as we know? Is 10,000 10,000?
I think there is patient-to-patient variation. We know that there will be some important baseline risk of bleeding in a patient with a platelet count of 10,000. I mentioned the good practice statement, so that could potentially modify the overall bleeding risk. And then there may be other clinical factors looking at the epidemiology of actual bleeding risk. If you look at all patients with platelet count of 10,000, you also have to recognize that how bleeding is measured from one study to the next varies. A lot of them will use trials in hematology oncology patients will use the WHO grading system, but even how that system is implemented from one trial to the next varied. The definition was often modified from one trial to the next. So we tried to use general categories of WHO grade 2 through 4 bleeding or equivalent and grade 3 through 4 bleeding or equivalent for the higher bleeding risk scenarios. So I think there is important patient-to-patient variability in bleeding risk. The real question that we were often asking was, how does a liberal platelet transfusion strategy potentially modify that bleeding risk compared to a restrictive strategy?
So let's go back to the process of creating this guideline. Who is on the committee and how were they chosen?
Yeah, so we had a steering committee that had about 4 people on the core steering committee. Myself, Simon Stanworth from Oxford, Susan Nahirniak from Alberta, and Brenda Grossman from Washington University. We're very fortunate to work with the grade methodologist, Dr. Gordon Guyatt, who is the first person to have published on the term evidence-based medicine in 1991.
That's where I've seen his name.
So yeah, Gordon is incredible, his level of expertise. We had systematic review methodologists as well, Artie Bafla and Sandy White. And then we had a panel of clinical experts across different clinical practice settings. So we did have transfusion medicine physicians like me, but then we had several physicians from other areas of practice, hematology, oncology, neurosurgery, interventional radiology. Wanted to make sure we had representation for areas where platelet transfusion may be commonly considered. And then very importantly, certainly last but not least, we had patient partners. So we have patients on the panel who have gone through an illness where they experienced platelet transfusion, oftentimes many times, and they participate in the panel, provide feedback, and often keep us grounded as we start to dive into the minutia of the evidence and so forth. It was kind of a blessing for us to be able to work with our wonderful patient partners too.
I'm curious, was it difficult to recruit patient partners?
That's a great question. We had two main patient partners for our panel. One was actually a patient that we knew here locally, and he's fantastic and very open to participating and speaking up and providing his insights and input. And then we had another patient partner from Canada who was also extremely insightful, but just had a different approach to thinking about transfusion and providing feedback. But their input was absolutely key and just helping us think about and checking us as we discussed the evidence and tried to formulate the recommendations.
Talk a little bit about the types of science that were considered and studied and ultimately went into the guidelines. So you've mentioned randomized trials as one category. And I think listeners are familiar with the concept. Randomized trials are expensive to do, but where they're available, they're invaluable. It seems to me a lot of clinical practice guidelines also make heavy use of other types of data as well, retrospective analysis, and sometimes even expert opinion. Could you talk a little bit about how you thought about what science to include and under what circumstances you needed sort of what level of science?
Yes, that's a great question. I'll do my best to try to explain it in a way that makes sense. So, I mentioned earlier that our overarching sort of analytical framework was we looked at different patient populations and then we compared interventions and comparisons that were either restrictive, so fewer amounts of platelets transfused, to liberal strategies, greater amounts of platelets transfused. And then the outcome could be looking at mortality or bleeding, as mentioned. So that could take the form, as you mentioned, of a randomized controlled trial for a particular patient population and, how they implemented restrictive and liberal. And those were our first choice, right? So if we were thinking about the evidence in a particular patient population, we looked at randomized controlled trials first.
There were quite a number of randomized trials that you included in your analysis, which by itself I think is pretty interesting that there have been a number of randomized trials of platelet transfusion. Is transfusion medicine a field that does a better job initiating and conducting randomized trials?
So we identified 21 randomized trials for inclusion in our analysis.
That strikes me as quite a few.
Now, some of them, the sample size was not particularly large, which is a limitation, and it gives you less confidence in the estimate. But having 21 of them allows us also to think about patterns and relative effects. So looking at the evidence, the pattern of the evidence across different patient populations. I think in some ways we've had some very helpful trials to move us forward. Implementing trials like this, though, is an incredible amount of work, especially the larger multi-center trials. Also presents certain challenges related to blinding. It's hard to do blinding of patients and practitioners sometimes for transfusion trials. Ideally, you, for bleeding outcomes, would blind the outcome assessor to the treatment assignment. But, I think we thankfully are getting more randomized trials published for platelet transfusion and certainly for red cell transfusion. We have a large number of trials. So they're increasing, which is fantastic to help increase our certainty in the evidence that exists. And as mentioned, we have 21 randomized trials that we identified, and those were sort of the top priority. And then when we put the evidence together related to, let's say, a specific patient population, patients undergoing particular procedure, central line, central venous catheter placement or something like that, we focus on, say, randomized trials first, and we evaluate using this methodology called grade methodology. What's the certainty of the evidence there? So we look at what's the impact of restrictive versus liberal on a bleeding outcome, for example. And then how certain are we in the evidence? And we look at things like risk of bias from those studies. And then one of the nice things is randomized trials reduce risk of bias. We look at the confidence interval, so the precision of the estimate. How confident are we that that really represents truth? And we basically divide it into 4 categories. So it can be high certainty, moderate certainty, low or very low certainty evidence. For situations where we had a randomized trial, but it generated very low certainty evidence, then we would turn our attention to other types of studies, like observational studies that are not randomized. I should mention before all of this, randomized trials will typically start as high certainty evidence, and then they can be rated down for certain things like concerns about precision or risk of bias. Observational studies start at low certainty evidence, and they can be rated up, not too commonly, but it's possible, or oftentimes will be rated down to very low certainty evidence. And so for a randomized trial, if we only had randomized trials that generated very low certainty evidence in our meta-analysis when we pool the trials together, then we would start to think about observational studies. For observational studies that involved an intervention like liberal versus restrictive platelet transfusion strategies, we only considered studies that basically adjusted for confounders using something called propensity matching, where you look to match patients to try to reduce the risk of confounding so that you're ideally trying to compare two fairly similar patient populations.
So can you give an example of where you needed to go to observational studies?
Yes. And there were some settings where we had no randomized trials at all. And so then we would also turn our attention to these, for example, propensity matched adjusted observational studies. So one would be in patients with consumptive thrombocytopenia due to critical illness. So patients in the critical care setting who are consuming platelets, like those with sepsis, for example. We didn't have a randomized trial specifically looking at that population in adults, but we did have an adjusted observational study. So we looked at the results of that study and the impact there, and just it will have a very low certainty of evidence was what we ended up judging it to be based on some of the considerations I mentioned. But that was a situation where we turned our attention to observational evidence, and it can be useful in those settings, even if it's not the ideal moderate or high certainty evidence. And then there's one other setting that I think is important to mention where we took a unique approach to analysis, and that is for lumbar puncture, so a spinal tap in thrombocytopenic patients. So we don't have randomized trials comparing restrictive and liberal strategies in patients undergoing a lumbar puncture with low platelet counts. But we thought the outcome of greatest concern was a spinal hematoma, so an important bleed in the spine, which can have major consequences. We want to avoid those outcomes. But those outcomes are fairly rare. And so what we did was we identified observational studies that reported the rate of spinal hematoma in patients with very low platelet counts measured just before the lumbar puncture. And our hypothesis was that bleeding rates are actually near zero. And you can imagine if, let's say, your risk of something is actually zero, then looking at the intervention versus the comparator doesn't really matter because you can't prevent an event that does not occur. And so we identified 6 observational studies that reported rates of spinal hematoma and lumbar puncture. And the point estimate was 0.8 events per 1,000 lumbar punctures. And so, first of all, the rate is very low and it's near zero. And then the likelihood that platelet transfusion would even prevent a rare event is also an open question, going back to what I mentioned about relative effects. And I won't get too much into the weeds here. Those were observational studies, but we were able to generate moderate certainty evidence because the event rate estimate was near zero, and the likelihood of a liberal strategy to prevent that important outcome, spinal hematoma, would be exceedingly low. And so the prior AABB guideline 10 years ago, the platelet count threshold in lumbar puncture was less than 50,000. And we changed that for this updated guideline to less than 20,000. So it's a fairly substantial change. We did another analysis in patients with platelet counts even below 20,000, just to look at that as well. And among the studies that we found, we had fewer studies and a smaller sample size, but there were still 0 events that occurred. So our estimate was actually 0, even for patients at platelet counts less than 20,000. But we also recognize this is a big change going from 50,000 to 20,000. And so we thought that specific recommendation of less than 20,000 was practical for implementation. And so That's another important point to these guidelines. We put together the evidence. Sometimes the definitions of restrictive and liberal varied between trials for a specific population, but then we had to make a judgment about what the specific implementation strategy would be for recommendations. We had to pick a threshold, and we did our best as a panel to pick one that we thought was in line with the best available evidence.
Did any of your recommendations need to rely on expert opinion?
So not expert opinion alone. And Gordon would say, experience is a form of evidence, not the most ideal form of evidence, but it is a form of evidence. But I will say we did consider something called indirect evidence. So again, when we looked at the randomized trials, the 21 randomized trials across populations, we found a pattern of no difference between restrictive and liberal for bleeding and mortality. And so when thinking about other settings where we thought clinicians would want guidance, but we didn't actually have direct evidence for that population that met our inclusion criteria. So a great example would be patients undergoing major surgery. Surprisingly, we didn't really have great direct evidence evaluating different platelet transfusion strategies, but we made what we thought was a practical threshold recommendation, platelet count less than 50,000, which recognizes the sort of higher risk of bleeding for a major surgery compared to more minor procedures. But we did that in the absence of direct evidence. Another setting would be patients with intracranial hemorrhage. So we do have a trial in patients with spontaneous intracranial hemorrhage, and we actually extended the recommendation to include also patients who had intracranial hemorrhage due to trauma, traumatic intracranial hemorrhage there. And so that latter one was based on very low certainty evidence that was indirect evidence from the randomized trial in spontaneous intracranial hemorrhage. So indirect evidence can be useful, especially when you have multiple trials across populations, because the pattern and relative impact tends to be constant.
So one of the conclusions I'm drawing here from what you're describing is that maybe we need to think of this as sort of a portfolio approach, that we're never going to answer all clinical questions with randomized trials. And so we're always going to need other forms of evidence. And maybe the more we gather, the better.
I think so. There are trials that are ongoing that are varying thresholds. So if you've heard of things like adaptive randomized trials, if we're recommending a platelet count threshold of 50,000 in a particular setting, one thing I want to mention for the audience is that the likelihood there's a stepwise benefit from when you're just below 50,000 to now just above 50,000.
49 versus 51.
Right. The likelihood that you jump to some important stepwise benefit to improve the outcomes I mentioned is probably not very likely that there are stepwise benefits there. But the adaptive trials can be helpful in a setting like this where you can vary the platelet count threshold multiple times through a randomized trial to sort of arrive at what seems like the most reasonable overall approach based on the evidence. So I think there are new ways to do trials that can be quite useful, and we welcome additional evidence, especially if it helps increase our evidence certainty for some of these settings where we have very low certainty evidence or where we've made conditional recommendations or even things that shift our thinking. Absolutely welcome those.
So for my last set of questions, maybe we'll get a little bit philosophical about the nature of science and experts and consensus. Historically, in scientific medicine, which is the field that we're in, certainly over the last century at least, there's been a really high value placed on the importance of experts. And when you create a guideline, you're getting a whole bunch of experts together, you're producing a consensus document. To me, that feels like sort of the epitome of expert-driven policy. So against that backdrop, there's also a more recent cultural thing going on, and I think it's not just the US, I think this is probably global, of questioning the value of experts. Are experts always right? I mean, some of this gets extreme, like do we trust vaccine experts or global warming experts? On the other hand, we know experts aren't always right. The current FDA head, Marty McCary, published a book. I don't know if you saw this. I haven't actually read it, I'll confess, but I heard about it. He published a book entirely about clinical scientific groupthink and where it can go wrong. And he uses this example of peanut allergies, where the pediatricians back in the 90s had this sort of expert opinion-driven idea that you shouldn't give babies peanut products. under the theory that it might reduce the risk of allergies, and it turned out that it had exactly the opposite effect. Now, there were no randomized trials there, but still, it was an expert consensus-driven process that turned out to go wrong. So where I'm getting here is, having just gone through this multiple year project, how long did it take you?
2 years for me.
Having just gone through that long process of producing an expert-driven consensus document, what are your thoughts about scientific consensus and the role that it should play in clinical medicine?
I think that's a great and very interesting question. And first of all, I'd say we all are human and have biases, right? I think everyone has some degree of bias, and it's how do we handle our biases and trying to handle them as best we can and recognizing that we have them. The other thing I would say is sometimes it seems like there's a tendency to think about result of a scientific study as a black and white finding. But what we've been talking about a lot during this interview is evidence certainty, strength of recommendation, strong and conditional, where you can start to incorporate things that I think are really important. And that's the concept of uncertainty. So we may have evidence that we generate, and we have to make judgments along the way, but we try to follow good methods. But at the end of the day, we have a level of certainty surrounding that evidence. And then at the end of the day, we still have to make a decision too. So we may make a recommendation for, let's say, a restrictive platelet transfusion strategy. That may be based on the best available evidence, what seems to make the most sense. But I think being transparent that we still have some degree of uncertainty in these settings can be really helpful in building trust, because it shows that we aren't 100% certain. We're open to the possibility that things could change with more trials that are larger, for example.
Almost certainly will change, at least in some ways.
Well, maybe the likelihood that the direction of the recommendation changes is probably small, but the certainty of the evidence could change. We could become more certain about the effect. For settings where we have, let's say, very low certainty evidence in anywhere in clinical medicine, that's where it has more of a possibility to change. And that's kind of incorporated at least into the grade methodology system. But I think if we consider ourselves experts and we're trying to communicate to different groups, I do think in some ways we should try to make it incumbent upon us to communicate it clearly and acknowledge that, for example, in this case, while we think restrictive is the best thing to do for this particular setting, there's some degree of uncertainty. Like, that's built into the method, being as transparent as you can. So there are recommendations for trustworthy clinical practice guideline formation, for example, thinking about disclosing potential conflicts of interest. How do you mitigate potential conflicts of interest? So somebody was a primary investigator on a trial. We didn't have them take part in discussions for recommendations related to that particular setting or vote for particular recommendations. I think it's an interesting time in the world right now. Some of it feels perhaps hard to control, but one thing at least that I think about is when we're trying to communicate these things, being as clear and transparent as possible, while also recognizing some degree of uncertainty. Again, we also have potential biases, but that's where we're getting a broad, diverse panel with people who practice in different areas, having patient partners, people from different parts of the world, I think can add value to the group. And hopefully over time, we can generate more trust amongst the public, for example, and less distrust. But if there is true groupthink, I think that can be a problem as well. So I think one thing, working with Gordon in particular, he values, and I do too, not deciding up front that you know what the answer is, right? Before you go through the grade process, analyze the data, synthesize the evidence, and be open to changing your mind. You know, we've done podcasts before where we talk about looking at data and understanding practice. And early on in my career, I kind of realized that some assumptions that I had were not supported by the data about how we were practicing at the time, for example. So I think at least doing your best to try to actively think about those things and making some effort to mitigate them can potentially be helpful. But as I said, it's also an interesting time in the world.
Ryan Metcalf, thank you for being on LabMind yet again.
Always a pleasure. Thank you, Brian.
LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.